Good afternoon. We're going to start in about a minute. We see folks are still entering the room. So good afternoon, everyone. Welcome. I'm Daria Bacher-Lattimore. I'm the president of the National Alliance for HIV Education and Workforce Development, also called Nahood. And I'm joined here with my colleague, Liz Lasso. We are welcoming you to our webinar series, Bridging HIV and Substance Use Disorder Innovations in the Field. Next slide, please. So a little bit about Nahood. It's a membership organization of the 8 regional and 2 national AIDS education and training centers, or the AETCs. We were established in 2010, and we support the AETCs, a component of the HRSA-funded Ryan White HIV/AIDS program, which have an explicit directive to build and maintain a well-educated and culturally sensitive health professional workforce that can provide prevention, diagnosis, care, and treatment, medical management for people at risk for and living with HIV. Nahood collaborates with multiple organizations in order to promote and educate on the work of the AETC program. Next slide. And one of those collaborations is with the Opioid Response Network. Since 2018, Nahood has been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network to address the intersection of HIV and opioid use disorder. ORN was created to support efforts in addressing prevention, treatment, and recovery of opioid use disorder, and it provides free resources and technical assistance locally in communities across the United States and its territories. So you can visit the ORN website for more information and even submit a request for technical assistance. Next, thank you. Today's presentation will include continuing education credits in medicine, nursing, and social work. We also offer a certificate of attendance if you so desire. The post-evaluation survey is going to be emailed to you after today's webinar, and please complete it within 2 weeks so we can get you those credits. We'll also probably put that link in the chat towards the end of the presentation, so you can link to it there as well. Again, so complete that evaluation, because once we get that, we can then send you that certificate. So we will be emailing you the certificates within 2 weeks of completing the evaluation. Okay, so with no further ado, I'd like to introduce to today's speaker, and actually for welcoming back today's speaker. Today's speaker is Yona Tangi, who practices in primary care at Whitman Walker Health, with a focus on providing holistic care to underserved populations, especially sexual and gender diverse people, people who use drugs, and people living with HIV. Yona is a clinical instructor at the Yale School of Nursing and is a board member and current vice president for education at GLMA, Health Professionals Advancing LGBTQ Equality, the world's largest and oldest association of LGBTQ+ healthcare professionals. Yona is a graduate of the Physician Associate Program at Yale School of Medicine, where they sat on the Dean's Advisory Council for LGBTQI+ affairs. Their research and educational advocacy focuses on safety optimization for people who participate in Chemsex. They are the founder of ChemsexHarmReduction.org, an educational resource for providers and people who participate in Chemsex. Yona has a passion for event planning as well as community advocacy and engagement. Previously, they shared their expertise with AIDS Project and the LBGTPA Caucus. There's a lot of letters and a lot of acronyms in our field, and sat on the executive board of the Brigham and Women's Hospital LGBTQ+ Employee Resource Group. So welcome, Yona. We're very pleased to have you.
Thank you. I'm so excited to be here again today with you all. And I'd love to make this as interactive as possible. So please use the chat, talk with each other, submit questions through the Q&A feature. I'm very excited that Dr. Daria will be helping me and alerting me to these questions. I want to make this as much as a conversation in webinar mode as we can. And we'll go from there. So without further ado, just pull up the chat. Let's get started. So today we're going to be talking about evidence-based treatments for chemsex use disorders. So specifically thinking about both the stimulants and depressants associated with chemsex, which is something that we see especially in queer communities. I have no financial disclosures to disclose. As Daria already mentioned, I'm a clinical provider at Women Walker Health, and I have various other affiliations. I will not repeat them. And I will not belabor these points, but what we're going to start out is we're going to use cases. And that's why I really want to make this interactive and I really want to get questions. But we're going to use cases to guide us through thinking about how we can best care for people living with chemsex use disorders, again, both the stimulant and depressant, how we can provide both harm reduction, how we can also provide evidence-based pharmaceutical treatments, and also thinking about those holistic elements as well. Because as we'll discuss through our first case, social service really is a form of the treatment, and each piece is an equal piece and just as vital in helping these people the best as we can. And so I hope that by the end of today, you'll have learned a little bit more about this community, a little bit more about chemsex, and feel more confident about being able to apply the research that's out there. And the other thing that I really love to get through today is I know that there's probably many researchers out there as well, or people who participate in research or work at a clinical site. And I'd really love to also, it'll be a little research heavy today because I want us to also think about how we can interrogate the research and think about what needs to be done in the future to make substance use disorder research that is more holistic and more aimed at improving the quality of life of people who use substances rather than just focusing on abstinence. So regularly, I'd love for people to read the case, but that would be very laborsome this way. So you'll have to deal with my voice quite a bit today. But again, please use the chat and talk with each other. So our first case narrative, Ricky is a 29-year-old male who uses pronouns he and him, living with HIV, who presents for a hospital follow-up after he was seen in the emergency department for paranoia and odd behavior. In the last 5 years, his only other hospitalization was 3 years ago for a burn on his hand. Ricky reports fair adherence with antiretroviral therapy for his HIV, but sometimes he loses track of time. Ricky is currently staying with a buddy. He reports that he is in between jobs doing things here and there. Ricky reports using Tina, which is the colloquial term for methamphetamines, every week with his buddy and at parties. That spelling is also the colloquial spelling. He has not had a lease in his own name in 4 years. He has moved from Atlanta to New York City 6 years ago and does not have family in the area. He reports occasional associated use of G, tadalafil, and poppers, and occasional attendance of saunas and sex venues. He reports semi-secure access to food and feels safe at his buddy's place. He reports his motivations for substance use are fun, feeling more like himself, and the connections. While he reports that some are thieves, he feels that he is less judged at parties. And so you'll see that the narratives we'll be working with today sort of take that biopsychosocial approach, looking not just at the actual medical pieces, but at some of the other pieces as well. So that way we can start to build a holistic treatment plan. So again, I always love to start off with a little social theory, and I'll bring us back into how this is evidence-based and how this is treatment, especially like taking the harm reduction approach. But first, I like to talk about why chemsex is different. And this is going to be important as well as we look at the different research studies thinking about different options there are for evidence-based treatments. Chemsex is different from other use of the same substance in that, well, actually, this is sort of shared between the substances. It's a form of escape for many people. What they're escaping, though, if we're talking about the sexual and gender diverse community, can be a little bit different. We're talking about people who are escaping different forms of oppression than maybe others are. Chemsex, as also a really wonderful social theorist, Joao Florencio, writes, is also a form of material and cultural survival. So oftentimes when we're thinking about some of our folks who may be using opioids or other substances, a lot of the counseling goes around building relationships with people who don't use substances, about thinking about having them critically interrogate the relationships with other people who are related to their use. But what's important to think about with Chemsex specifically is it's not just perhaps buddies who use, it's also a culture in of itself. It's highly linked with queer culture and queer culturally defined spaces. These sex venues, these gay clubs, these circuit parties where people use these substances, they have existed for a very long time, and they are centers of queer culture. And so it's very important to think about that when we're dealing with chemsex, if we're really just focusing on being absence-based or on severing, like we might think about in older approaches, you're really not just severing them from a substance, you may be severing them from their connection to a culture. And of course, many people, it's their form of material survival as well. They use underground economies in order to support themselves related to substance use and to sex. And then what's very interesting that I really love that this particular theorist writes about is this idea that chemsex can be an affirming experience, a place where people who are sometimes marginalized get to feel powerful, get to feel sexy, and get to and have an affirming experience of their identity. And so that, of course, can be very particularly alluring. And again, if we're thinking about a holistic treatment plan, we have to think about how those people are going to find that again without these substances if they no longer want to use them. So with that, I'd love to start with a poll everywhere. I'm very happy that it's already popped up. So if everyone has a mobile device or a dual screen or the ability just to go to another window, if you go ahead and type in that link at the very top, the pollev.com/yonatangi975, you'll be able to submit answers to this and it will build a really lovely word cloud. So we'll give a few minutes for this activity. And while we wait for responses, I'll peruse the chat a bit. I'm very happy to see we have a lot of diverse disciplines here today. That's always great. And also, if you're finding that it's too hard to use the poll everywhere, feel free to also submit your answers via the chat. And please also let me know if anyone's having technical difficulties. Here we go. So some of the words I'm looking at are loss of control, it looks like, compulsatory, dependence, stimulus, disruption, mental. Obviously, substance and substance use seem to be the largest ones. But I think this is a really great word cloud. And you know, I'm very impressed, and I think it just goes to the people that we have on the call. I don't believe I see the word abuse on here, which is wonderful. Because we're really trying to move past that word because it can be very harmful to the people that we're trying to treat. But I think that there's a lot of really great ideas on here and what we think about substance use, and I'm actually seeing a lot of the diagnostic criteria we're about to delve in, things about like loss of control. I see some words related to social function like families, emotional health, chronic, co-occurring. These are really great. And thank you for participating in this little activity. So today, rather than going through all the different theories like we did last time, I'm just going to mention very briefly the idea of syndemic theory. So syndemic theory is the most, I would say, research-proven theory of what a substance use disorder is and how it develops. And what this theory is that addiction is not, or a substance use disorder is not a chronic brain disease. It's not a moral choice, but it's a multifactorial syndrome that is influenced by people's experienced forms of depression and or oppression, and also their life experiences. So things like education, wealth or poverty, race, which in the form of oppressions that come with race, gender and sexuality in the forms of oppression that come with that. All of these contribute and sort of cooperate in a way that can lead to the development of a substance use disorder. And as you'll see there in those citations at the bottom, advanced statistical models have proven that we can actually predict based on things like ACEs, adverse childhood experiences, and all these other factors, we can predict with high accuracy who might develop a substance use disorder. And this theory actually itself is not really that new. It's in Western ideas. It's been around for quite a few decades. But I recently went to a really wonderful lecture about how the idea of syndemic theory is actually also present for much longer periods of time, or has been present in non-Western ways of knowing and indigenous ways of knowing. So when we think about a substance use disorder, or we think about addiction, I encourage you to think about it as not just one thing, but as a contribution or a collaboration of multiple negative factors working together to affect a person. So when we specifically think about what we are treating as healthcare providers, as clinicians, whether that be as counselors, whether that be as direct service providers, or et cetera, we're thinking about these DSM-5 criteria. Now, I think it's really important that if you're actually working with someone on substance use, to actually really do a proper diagnosis, to grade all of these criteria, ask them these questions. But when I think about it in my head, what I like to do is, and I think about sort of assessing response to treatment, what I encourage is thinking about these, splitting it into these 4 categories that are much easier to remember when you're just thinking about response to treatment. Thinking about loss of control and asking them about things related to that. Thinking about whether or not they're experiencing cravings. That's a very simple question. Thinking about social dysfunction and consequences, but we'll relate this back to that case at the end. Thinking about, how are they supporting themselves? Are they able to maintain employment that they find fulfilling? Are they able to maintain friendships and family relationships? And then thinking about the more obvious thing that we oftentimes focus on is the physical dependence or withdrawal symptoms. But remember, there's 4 pieces to this, and those other pieces are just as important. And oftentimes we are not both screening and assessing that social dysfunction and consequence. And that's really important when we're thinking about assessing a treatment response to any of our treatments. So what I'd like to also use this case to encourage you to think about is that substance use, based on those criteria, it's a spectrum. It's graded mild, moderate, or severe based on how many of those criteria they have, and that it's not fixed. When you meet a person at different points in their life, they're not necessarily always going to be or chronically have, like, for example, a severe substance use disorder. It's kind of like a gas measurement. It goes up and down. It can go up and down through the lifetime. And what do we know from the statistical model lead people to go up and down that spectrum? Things and crises like mental health problems, housing instability, isolation, and poverty. These lead people deeper and deeper into a disordered substance use, a disordered relationship with a substance. And things like housing, fulfillment, and basic needs, community has been shown in statistics to be really important. These things are a form of treatment for substance use disorder. They alleviate the symptoms, they give people back control. So what I'd also like to do is talk about this in reference to burnout, is that this is part of the treatment. And as healthcare providers, oftentimes we get very discouraged when treating people struggling with substance use and struggling to meet their goals with substance use. But it's important to remember that no medication, although we're going to be talking a lot of medications today, no medication in of itself is going to be the full scope of treatment. And that can really alleviate some of the burnout, realizing that there are other pieces that need to happen. And that's also where multidisciplinary teams come in. The importance of having social workers and care navigators on site. And in HIV treatment, we know that this works really well for people. It's no different for integrating substance use care. And we know that the more that we integrate more types of care, the better outcomes there are. We know that people who receive trans care with their HIV care are more likely to be engaged in care. Same with substance use disorder. If you're engaging them for HIV, for Hep C, and their substance use disorder and their other needs, it's that holistic model, people do better. So relating this back to this case, or actually we'll move on to this other case, but before I'm going to go back and relating it to that first case that we had, let's talk about in the chat some of the things that we're specifically seeing in terms of social support that that person needs. Forgive me if you're motion sick, but I am actually going to scroll back. I know I don't like when people do it, but I want us to be able to look at it. So looking at this particular person, what are some of the flags that this person's relationship with substance use has become disordered? And what interventions based on that might we think that this person might need? Yes, someone talked about housing. His housing is no longer stable, and he's using he's accessing housing through his substance use. Social wise, his social relationships, you're correct, Christopher, have become tied to his use patterns as well. Yep, stable housing is going to be absolutely things, paranoia and odd behaviors. Yeah. So, this could be a sign also that he's losing, if we're thinking about those DSM criteria, this is loss of control. If he is no longer able to control his substance use so much that he is developing symptoms of not sleeping too much or not sleeping enough and having sort of meth paranoia, that's a sign that he is losing control of his substance use. Food insecurity, losing track of time, his inability to keep a steady income. Absolutely. Absolutely. And if we're thinking about this also from a holistic counseling perspective, more about those relationships, he likes some of those relationships at parties, but there's a lot of distrust there too. So I think that'd be something that we'd really want to delve into. Wonderful things in the chat. Thank you guys so much for participating. And again, bear with me on the motion sickness. I apologize. So moving into our next case. And this we'll use to delve into more of that harm reduction size and motivational interviewing. We'll not be doing extensive motivational interviewing training today, but I highly encourage it for everyone, healthcare providers, counselors, etc. So we have a 24-year-old male assigned male at birth who uses pronouns he and him, who is gay identifying and is a financial consultant, and he presents with a bad headache. The patient states he just got back from market days in Chicago, which is the circuit party for those who don't know, and his head has been splitting ever since. He is living with HIV, he has an undetectable viral load stable on Bic/Taf emtricitabine, and upon questioning, he reports that he's had about 26 male partners since he was last trusted and treated for rectal and throat gonorrhea about a month ago. He reports receptive anal intercourse, receptive oral intercourse, insertive anal intercourse, insertive oral intercourse. And I apologize, I'm trying to say all these acronyms so that way they're clear to you. And he reports that he enjoys using substances as that they provide relief from his busy work life. Upon further questioning, he got a few hours of sleep here and there while at market days. He started by using MDMA and G, which is a reference to different chemicals as we'll talk about later, but usually either GHB, GBL, or 1,4-BD. And then the second day, he started using ketamine and occasional bumps of cocaine to keep him going. And then more G when he wanted to have sex. He reports that he is taking his Bic/Taf FTC, but he forgets a dose maybe once or twice a month if he crashes after a long weekend. The patient states that he sleeps regularly on weekdays, but that once every 2 or 3 months, he has needed to call out of work on a Monday because he needed extra recovery time in order to feel rested. The patient states that he usually has no issues with his work performance, but is concerned today as he has called out more frequently in the last 2 months. So right off the bat, just thinking about our last case, what are sort of the social frameworks that we're concerned about here? What are some of the issues that we're seeing on the social side? And thinking about those DSM criteria about disordered use, what are some warning flags that maybe this person is moving from substance use into a mild to moderate substance use disorder? Needing more recovery time and missing work, absolutely. Calling out of work, sexual behaviors, especially using more than you want to or you meant to is one of the criteria, absolutely. Affecting responsibilities, absolutely. Great. So I really believe in harm reduction counseling, and it is my firm belief also that as medical providers, whether that be PAs, NPs, or physicians, that this is part of what we should be doing from a primary care and HIV primary care model. That's important for us to do this. Now, right off to start, how do you start off with a conversation? Well, when you get a narrative like this, one of the ways that you actually acquire this narrative is by being non-judgmental and talking about their use with interest. A lot of people out there who use substances, especially like this person, kind of self-identify as drug nerds. They are excited about their use. And when you talk about their use with interest, not with just curiosity, but with interest, again, looking for those different things that we might be doing safety counseling for, they are more likely to open up. And so then you can start to talk to them about different ideas about general safety. Hydration and nutrition. Talking to this person about the importance, and we'll get into this more later with those specific substances, of hydrating their body and providing themselves with adequate nutrition. Especially when we start talking about stimulants, Ensure is an intervention of itself. It's important, if needle exchanges and other places like that, if you're involved with those things, Ensure is a really great tool because for people using stimulants, it's hard. They don't have an appetite for them to access adequate nutrition, and not hydrating themselves and not accessing nutrition just makes it that much tougher on their bodies and leads to problem. So something as simple as talking to them about water and getting some Boost Plus or Ensure is a really great idea. And I am not paid by Ensure. Situational safety with some of these substances, especially when the depressants, when we start talking about those, can put you at risk of sexual abuse. So talking to them about ideas like a buddy system, about going to parties, circuit parties, or to sex parties with a buddy who, so that way there's someone that, should something happen to them, they have someone they trust who can remove them from that situation. Accountability with their friends. You know, I think a really worrisome sign with substance use is when people are drinking alone, or when they lie to others about their substance use, when they're afraid to tell their friends or close friends or even their family about their substance use, or they're hiding things from people, because that really just, again, it leads them down that spectrum. So talking to them about being open, maybe with a trusted friend, of bringing that friend in on what they think is their version of a controlled substance use, so that way their friend can hold them accountable if they find that they are not actually doing or interacting with the substance the way they want to, if they're not actually using as much as they said they were using, if they're using more. And then, of course, as we know in HIV prevention, it's important to also think about those STIs. U equals U, you know, that's a form of treatment as prevention. It's so important, PrEP and PEP. And then this is off-label, but utilization of doxy-PEP. If you guys are unfamiliar, that could also be its own lecture. But, you know, we've seen it in trials now, both in people living with HIV and people who are HIV negative on PrEP. It's effective, and especially for people who are having a high volume of partners and going to sex venues. It's a very, very important and useful and utilitarian intervention. And there's a lot of data on that. I would suggest, if you're unfamiliar, dipping a little deeper. And then, of course, asking them about their supplies. So if they are injecting something, where are they getting their needles? Where are they getting their other equipment? Where are they sharing straws with people? You know, you can get Hep C by sharing straws for snorting, things like that. Asking about where they get their supplies and providing them with information. I really think it's important that every single person in a healthcare space should know where their local syringe exchanges are if you are not providing that service. So that way you can refer people, because that's absolutely essential for all kinds of health, but especially when we're thinking about HIV and hepatitis C prevention, another bloodborne illness. So what are some harm reduction strategies for this patient who uses poppers and ketamines? Well, the biggest thing I think about is the interaction with the PDE5 inhibitors, things like sildenafil or tadalafil. Every time I actually prescribe either one of those medicines, I don't even care what their sexuality is. I don't think about it. I actually write in the prescription instructions, don't use with poppers, because that's really the major interaction that we're worried about. Now, some of you may have heard in the past that there is an immune effect to poppers. I could go into that research, but that is simply not true. There's a long history there. And, you know, they are important in queer communities, especially important to some people. It's the only way that they can have sex comfortably. So they are an important piece of the community. Other things to think about, though, is that they are caustic and flammable, although most people know that already. And, you know, I put that on there. There are some strange case reports out there, but am I measuring G6PD, like deficiency in people who use poppers? Absolutely not. It's probably not an issue for most people. And, you know, I've only actually think I've seen people who are actually using poppers in a way that is disordered once or twice, and it was always in combination with other substances. So really, it's just that main key fact that it's important to tell everyone is that the interaction with the PDE5 inhibitors, because I actually have heard of 2 cases in my career, and I like to think of myself as not that old. And I've had 2 cases, granted, of people using multiple substances, of people who did have like cardiac failure after using poppers in combination with other substances, including a PDE5 inhibitor, and actually did unfortunately pass away. Now, when we're talking about ketamine, some harm reduction strategies for counselors, for healthcare providers to mention to patients, it's actually stronger in powder form than cocaine. And it's actually commonly used with cocaine because people love to mix uppers and downers. So letting people know that they should be using 1/4 to 1/3 of the amount of the cocaine they're using, so that way it's safe and they're not taking too much. But going back to those basic things, hydration and kidney health are essential. Ketamine use can actually lead to hematuria and to reduced kidney function. And so making sure that they're drinking copious amounts of water, actually, if they're doing ketamine, is important. And then thinking also about the route of administration. Of course, eating a substance is always the best way to take it. Very rarely will people be doing that. The vast majority of people snort ketamine. Injection use is not common because most people don't like actually that being that dissociated. Any questions so far before we move on to motivational interviewing? I'll take a now to look at the chat. I see a question about antibiotic resistance developing. You know, one of the things I always mention about people who are concerned about that, we routinely prescribe doxycycline for years for people with acne. This is something where we know that the research shows that, that it is efficacious for patients, that reduces STIs by 2/3. And what we found, although of course we need longer term data if we're talking about off-label use, the toxi-PEP, is so far we're not too concerned about it. What's actually interesting is that it's been studied in Europe as well as in the US. In the US, actually, a fair amount of gonorrhea, which is the one where we're thinking about resistance that we're primarily worried about, is actually still not resistance to doxycycline. But you know, pretty much all gonorrhea in Europe is. And so in Europe, when they use this drug, they really think about it as only preventing syphilis and only preventing chlamydia. But actually in the US, it actually seems to have an expanded range. That may change. That is true. That might change. And it also will change certainly as sexual networks are very international again, post-pandemic. But I still think that it's very important and efficacious. And if we're talking about, when we're thinking about antibiotic stewardship, there are a lot of more important things that are at much larger volumes that I think that are much more concerning, specifically prescription of antibiotics for like likely viral sinusitis, and also things like large prescriptions for acne, etc. Yep, I see a message about some research in Ontario that's very interesting. A project that we're actually involved with that I always love to talk about here at Whitman Walker is about harm reduction vending machines. I have seen and heard of success with those. And so especially if you're at a queer clinic like I am at Whitman Walker Health, those people are already interacting with services there. I think that a lot of, I'd be very interested to learn more about your research. But in my sort of colloquial experience, people who participate in Chemsex do not like accessing services that were made for people who use opioids. They think of themselves very differently, and those services are oftentimes not welcoming places for them. I think especially about drug state-run and state-funded drug rehab programs. I've had many patients with horrible experiences of like homophobia, transphobia, etc. And just also just not understanding, like staff who are not understanding about the context of this use. So if we're talking about the syringe exchange services, that's really true too. Lovely in DC, there's an amazing organization called HIPS. They are a mobile syringe exchange service. They really are built by and for queer people and the trans community. And I find that a lot of the people who are queer who use, at least in my experience, I'm providing care in this district, are actually willing to use those services because it's really made for them. And then also we are FQHC, so we're not able to directly supply needles and syringe products, but we do provide things now like fentanyl test strips, which I see there, things like sharps containers. That's something that people forget about because it's important to have safe disposal of sharps. And then also things like Narcan. I just give Narcan to everyone. Thank you. So I'll continue moving on now and talk a little bit about motivational interviewing briefly. But again, there's a lot of really great free trainings out there, and I encourage you to look them up and continue learning more. So what are some of the major tenets of motivational interviewing? What I like about motivational interviewing is it's not just about like a counseling or behavioral change technique. It's really about a form of providing care that is compassionate, that is based on human empathy. And so you'll see that's really the first tenet of motivational interviewing is expressing that empathy to the patient, letting them know that you care, that you're not just a cold white coat who is removed from the situation, is just thinking about that clinical medicine. And then another key point is developing the discrepancies and trying to promote the idea of change talk. So if we're thinking about that case with the financial consultant, thinking about how he sort of, in that case narrative, you heard that there was a little bit of hesitation, that the patient was starting to contemplate that maybe their use is not as controlled as they thought it was, that the consultant was worried that they are calling out more often. And so asking them more about that, making them actually start to build those associations is so much better than you trying to enforce those associations onto someone. Because if they make the connections, they're much stronger and they're much more likely to participate in care. Rolling with the resistance, you know, it's never helpful to build, in terms of a therapeutic relationship, to build conflict. And so directly confronting people with delusions or directly confronting people who are very resistant to change, who say, I can't do it, this isn't me, etc. Saying, yes, you can, is not going to be the thing that changes it. We want to do that. We want to like prompt them up, but rolling with the resistance, avoiding direct confrontation, and again, just expressing that empathy, trying to develop anything, asking them what they think would need to change, stuff like that. And then celebrating self-efficacy. Obviously, I don't share my clinical notes with you guys, but if you could, I actually often write in my note-taking, celebrated with patient. I believe that any small change that the patient is sharing with you or a person is sharing with you should be celebrated because change is incremental. We know that across the board in all walks of life. And so celebrating their self-efficacy, celebrating that restores agency to them, and it restores because a lot of these people have a lot of self-esteem issues that the systems reinforce. And, you know, like so many substance care systems reinforce these self-esteem issues, make people feel like failures if they are not able to get clean or achieve abstinence or fit a certain specific model of a person. And so trying to resist that, that patriarchal form of care, trying to really celebrate any change, I think is really important. And I think also there's a lovely nurse whose name escapes me now, who talks about the idea of love as a form of contingency management. And now I know we're bear with me on this one, but you know, I think what it is about expressing the empathy, even when people fail at their own goals. So that way they don't get more down on themselves, you know, trying to be as empathetic as possible. So what are some tools we can do to do this? Asking open-ended questions, especially where questions that patients will lead to reflect on themselves. And so that way they can really produce the content. Obviously, right now we're in a talk with, I'm talking a lot at you, but in a patient interview, you want to be doing the bare minimum amount of talking. You want to be eliciting things from them and then showing them that you're listening. How are you showing them that you're listening? Providing affirmation and validation for changes and for their experiences. You know, a lot of people, we get caught up in the idea that an experience, a side effect or something is not what's in the label, is not what we feel like is real, but you know, like perspective is reality, it's real for that patient. So rather than just saying, no, it's not that, affirming the experience itself. Oh, that must be scary that you felt so like nauseous and out of control. Something like that. And, you know, use that reflective listening. Take the piece of what they said to you and put it back just like that. And then finally, the way that you can guide the conversation is through summarizing, taking what they're saying and then reflecting it back to them and summarizing an idea. Well, it sounds to me like you've put all these pieces together and it sounds like you're actually ready to make a change. Would you say that that is true? Something like that. And so it's a very useful strategy. Questions we have, oh, I love that actually. I'm just looking at the chat now. We call this listen first. And, you know, there's motivational interviewing it's branded. It's a way that people are thinking about things, but this strategy has been around for a while. And absolutely, I think that motivational interviewing is really taking that harm reduction approach as well. And, you know, as we'll talk about later, recovery is self-defined. Not everyone defines recovery as no substance use, and we need to be okay with that. We need to realize that we need to help people the way they want to be helped with their goals, and that abstinence does not mean, again, abstinence does not mean that the substance use disorder is gone. The substance use disorder being gone is the absence of this disordered use criteria. Questions on motivational interviewing? I'll pause for a minute. Wonderful. So again, reflecting this back on this case, I think I kind of already took it away from you guys, but again, I'll just highlight talking to the patient and developing the change talk, mostly on those things at the end. That patient is concerned that he is called out more frequently, starting there, listening, validating his fears, validating his feelings, and then asking him about what needs to change. And, you know, for this patient, it may not be that they want to stop using substances. Maybe this patient just wants some support reducing their use and wants some counseling on accountability, on making a plan perhaps for a drug holiday, which is something we'll talk about later, of really trusting their own control by saying, you know what, I'm not going to use substances for the next 2 months. And that's how I'm going to prove to myself that I am in control and that I can reduce my tolerance so that I can use less in the future. Something like that. So moving into the next case, and this is where it's going to get really heavy in research, and we're really going to talk about this evidence-based treatments. We're going to spend the bulk of the time on methamphetamines, but we'll also talk about other ones. So JC is a 27-year-old non-binary person assigned male at birth who uses they, them pronouns, who is living with HIV. JC slams, which is the colloquial term for injecting meth, multiple times every week and has daily use of meth. JC used to work in food service, but now supports themselves through combinations of gig work and sex work. JC reports a regular sleep, sometimes staying up for 4 days on end. They also report inconsistent nutrition and often eat candy during benders to sustain themselves. JC today presents concerned as they feel like their stomach can no longer tolerate HIV medication. They report that they're not sure that they want to eliminate their use, but they want to significantly reduce it and stop slamming altogether. JC is Hep C negative, but recently had a scare, motivating their concern about slamming. JC has tried quitting cold turkey in the past, but has issues with depression, anxiety, and insomnia. They also get infrequent euphoric recall, which, especially for people that are injecting meth, is an experience where, because it's such a high, like a blast of dopamine, even after a long period of no use, a stimulus like seeing porn or seeing seeing a person that they are attracted to, or a thought popping into their head, can sort of perpetuate a full body experience where it feels like they're high again. And that can be very difficult for people who, especially those who are seeking abstinence-based recovery, because it really can lead to those returns to use. So before we go into the medication options, I want to take 2 pauses. I'd love if you guys could start talking about in the chat specifically what things that we're seeing based on the social services this patient might need, what motivational interviewing techniques we might use, specifically where we might target, etc. Thank you for Christopher for sharing. I'm excited that you feel like this is a safe space, and I hope that it is a safe space for everyone. So again, thinking about what social services this person might need and where we might target our motivational interviewing techniques. To Colleen, slam is the colloquial term for injecting. So people who use meth, again, it's a different culture, it's a different language from people who inject other drugs. Specifically, people who inject meth say slam. And so actually it's important to use that language, in my opinion, because people, if you say, do they inject drugs, will bristle at that. But if you say slam, I oftentimes find that people are more likely to give you an answer. It seems correct, Mary Riley, that they're motivated around some of their issues. Specifically, you're seeing at the end that they're concerned about slamming. Some assistance with food resources, perhaps counseling on Ensure would be great. Mental health services, absolutely. I see some more things about food insecurity programs. Absolutely, that's important, especially for their overall health. All right. And then community, absolutely. Community is protective, and it helps lead people. It helps lead people back down that spectrum. So very important. And needle exchange services, absolutely. Oh, I love that phrase, Christopher. The opposite of addiction is connection. So before we talk about the evidence-based treatments, let's talk a little bit about some of the things around it. Now, when we're talking about mental health diagnoses and mental health treatment around substance use disorders, there's a lot of issues that we run into commonly. One is the chicken or the egg problem, where people confuse, or it's difficult to discern the difference between substance-related psychiatric symptoms and symptoms that are actually causing the substance use that is a form of self-medication. Now, one thing I want to say, and I'm going to drive home a couple of points here that I think that are important in terms of justice and of thinking critically about how systems interact, is that meth high is not mania. They are not the same thing. It is an induced mania, but is not the same as mania that we see in bipolar. And that it's actually important to understand that, especially when we're talking about stimulant use, and also people who use stimulants and depressants intermittently, the high withdrawal dichotomies mimic mood cycling, but that does not mean that the person themselves is mood cycling. It's sort of a chicken or the egg problem. And this is where it gets confusing, is that anxiety and depression are extraordinarily common in people who are experiencing a substance use disorder, but it's hard to say if it is a result of the substance use or the driver of the use. So that's where doing, again, that biopsychosocial interview is going to be very helpful. Now, something I want to say is that there is a huge amount of over and misdiagnosis of bipolar and schizophrenia in people who use substances, especially along racial lines. And people who are white, they are most commonly overdiagnosed with bipolar, and people who are of color, they are most often diagnosed with schizophrenia. Now, this is not to say that there is a lot of over misdiagnosis generally. It's that it has to do a lot with the way EMRs work now. You know, and not every mental health diagnosis is made by someone who's a mental health professional who is going through those DSM-5 criteria and is really like doing a rigorous diagnostic process. And that's really, really key and important. And, you know, nowadays it's so easy for someone just to add a bipolar diagnosis or a schizophrenia diagnosis into the chart, and that can follow a patient for a very long time. And then now that patients can see their records, have apps on their phones, they start to identify with that, even though it was never properly diagnosed. So what I encourage you to do is not necessarily say that all bipolar diagnoses is white people and all schizophrenia diagnoses of Black people are fake, but interrogate, are they using substances? Are we actually talking about substance-induced symptoms? And also, what was the rigor of the mental health diagnosis? Asking people when they were diagnosed, how were they diagnosed? Did someone just tell them offhand one time? Or was there a rigor diagnostic process? Because this is very important. And also, what these diagnoses do is they lead to treatments that are not correct for the substance the person is using. And we're going to talk about a lot of medications that are actually contraindicated in people using methamphetamines that are commonly used incorrectly because they are carrying misdiagnosed bipolar and schizophrenia diagnoses. So before we start prescribing, what do we want to do? Again, I said it earlier, recovery is patient defined. You want to know what their goals are, and you're going to try and target interventions to support those goals, which is also going to make them more adherent to treatment and more excited about treatment because you're working on what they want to happen rather than what you want to happen. Identify those psychiatric symptoms that they're experiencing. So for JC, that was insomnia, anxiety, depression, and side effects of concern to the patient. We're talking about, there's a lot of body dysmorphia in queer communities. Queer community, therefore, a lot of these people may be very concerned about weight gain. And so thinking about that critically and what interventions we're going to give to people and having an honest conversation, not just not saying those side effects because we think that the people aren't going to like them and aren't going to take it. Talking about sexual function, specifically for Chemsex, and this is what we're going to talk about more later about how the research is not all applicable. Sexual function and restoring it is really important. For some people, a key identification that they're really in a disordered use space is they no longer can have sex without drugs. And so if they're looking for a recovery, regardless of whether that's reduced use or no use, a big part of that may be being able to have sex again and relationships without substances. And we might need to actually focus on that. You know, tadalafil and sildenafil, where they do have that dangerous interaction with poppers, they actually can be important interventions for people to restore that sex life if they are no longer able to have a sex life without drugs. And then again, talking about those other social things and about other side effects. So before we talk about medications for methamphetamines, let's start by talking about their mechanism of action. And this is where we're going to spend the bulk of our time because I think methamphetamine use in the complex context is the biggest thing that we're seeing in terms of the most common drug, and that is true just across the board, but also where we see the most like sort of disability and the harm associated with it. So what do? They work on the neurotransmitters dopamine and norepinephrine, specifically dopamine. They increase energy and sex drive, which is why it's useful for chemsex. They reduce the need for sleep, reduce fatigue. They reduce inhibitions, make people feel powerful. At too high doses, they can lead to hyperfocus and thought blocking. They cause vasoconstriction, which leads to erectile dysfunction, and they increase touch and pleasure sensations. They can be eaten, smoked, or slammed, which is injected. And when we're talking about smoking, that can either be typically smoking with a ball pipe, which is direct heat into the lungs, or a water pipe, which brings it through water, which is actually a harm reduction technique. Water pipes are safer for the lungs over time because that heat injury actually is also leading to a lot of the issues when people are developing lung problems. Also, I can say from experience, oral is great. Make sure that you tell people if they're going to try and eat it to take capsules. A lot of patients out there, when you tell them to do oral, I've experienced this more than once, will start parachuting it, which means wrapping it up in a little piece of paper or toilet paper. I've seen people go to the hospital with severe GI symptoms, and it's partially because of the meth that they're eating, but also partially because they're eating so much toilet paper. So thinking about actually if they're going to do it orally, that they really need those capsules. Yes, and it can be snorted, although I find that people don't always like to snort meth because it's quite painful when you do so. So When we're talking about the chemsex context, I think the most research-supported medicine is mirtazapine for meth use. It's works on the alpha serotonin and histamine receptors, and it's basically, I think of it as the opposite of meth. It reduces anxiety, it improves insomnia by making people sleepy, and if they start taking it every day, it can restore that sleep-wake cycle. It increases the appetite, and this is important to explain to people because I find it helpful in getting them to take it, is unlike antipsychotics, it does not cause metabolic dysregulation. It just increases the appetite similar to cannabis. And when I explain it to people like that, they are far more willing to do it because if your diet doesn't change, you're not going to gain weight. So the other thing is that it's very safe to use even during active use. This is why we use it in older adults. It doesn't have a lot of interactions. And as I'll talk about later, it's very preferable to benzos. And part of that, as we'll talk about into the research later, is that benzos are one of those drugs that are absolutely contraindicated in meth use. There is now good data out there, and we'll talk about this study at the end, that actually shows that benzodiazepine exposure in people with a meth use disorder leads to poorer outcomes, higher all-cause mortality. So don't use benzos in these people. So the two studies for mirtazapine, the reason why they're specifically great is they're US based. So for most of you who are, I assuming, US based, they're most applicable, but more so, they were actually studied in queer people, MSM using meth, rather than just general stimulant users. Both of them were in San Francisco. This is the first one. They were randomized double-blind placebo trials. And what I want to show here is that even though the sample size was small, they saw, even with low to moderate adherence, significant reductions in meth use and reductions in HIV sexual risk behaviors. And in the second study, again, they replicated those findings and also saw benefits for insomnia and depressive scores. And what's great about this second study is they actually also included transgender women. They tried to recruit transgender men, but unfortunately were unsuccessful. So two really great studies showing benefit from mirtazapine for meth. So I think that this is a staple for Chemsex specifically because it has been studied in this context. And I'm going to give you a sort of a precursor that this unfortunately is the only medication that has been studied really in the specific Chemsex context. All right. So questions on mirtazapine, and I'm going to take some time. Yes, absolutely. Booty bumping, sometimes people mix some G in there too. And for the body dysmorphia, absolutely. I think that's something to think about, and we'll talk about some of the other interventions. But I oftentimes will combine, I'll use these medications together. We can talk about that through the chat and have a conversation about it. But oftentimes I'll actually combine mirtazapine with bupropion as a way to sort of restore the sleep-wake cycle, bring them up and bring them down. And the fact that like bupropion actually is a little bit appetite suppressant makes them feel better that those sort of might cancel out. And again, it's really important to counsel them about the fact that mirtazapine does not actually cause direct weight gain. It increases appetite, which leads to weight gain. So it's a different mechanism. And I find that people find that information often more comforting as well. And mirtazapine also is very useful for people that are looking for a medication who are active use for come downs. It's much better than a benzo, and a lot of people use Xanax from the street. There actually is a study out there talking about the differences in the research between queer and non-queer use that showed that mirtazapine wasn't useful for heterosexual people as a withdrawal drug. But again, it seems to be very efficacious. And this is where I'm also going to highlight in the research that the research that's not in the Chemsex content, we shouldn't take that as absolutely applicable. We're going to try take the best of it as we can, but more research is really needed. And it's important to say that this is a different context and that changes it. It's a different animal. So bupropion for meth use, again, working on those same receptors as meth, dopamine and norepinephrine, which is why people have always thought that it would be helpful. It's an activating antidepressant. So it really treats the symptoms that people have when they're no longer using meth. That they're depressed, that they have a lower sex drive, that that their appetite, that they're hungry, etc., and that they are no longer able to focus. It's similar to and a cousin of the amphetamine stimulants. So again, we'll talk about this more as we go through in the long-acting stimulants, especially. It's sort of that same idea of methadone or buprenorphine as giving them a piece of it back, but in a safe way. So when we think about trials, I'm going to start off with these four. Of note, the Elkashelf and Anderson trial are paired studies and that they were done by the same research group. Now, what you can see here in terms of outcomes is that for the most part, that these were found, bupropion was only found to be effective for people with lower baseline use, meaning that they weren't injecting and they weren't using every day. Now, here are the things that I'm going to predicate off of these studies. Not a single one of these studies collected any sexual orientation or gender identities information. So if there were queer people in the studies, we simply do not know. Most of the studies that we're working with have relatively low sample sizes, and you'll see actually that as we talk about it later, they included multiple pieces of their intervention. All of them were placebo controlled, but all of them contained some level of counseling, either group therapy or CBT. Choctaw, as we'll talk about later, actually included contingency management, and I'll talk about why that might be a problem. And you can also see that the majority of these trials specifically used a lower dose of short-release bupropion rather than a higher dose of the XL bupropion. But besides that one at the end, we did see that same sort of efficacy for people with lower baseline use. And that is how I often think about it, is that if people are slamming, bupropion is not going, it's going to be the drop in the ocean. It's not going to be enough. And we'll talk about more later what might be better. But for people who are just smoking meth occasionally, this might be a really great intervention. Or for people who just want to reduce their use, who feel like that the withdrawals and are really bothersome, or like, for example, that financial consultant, this might be a really great intervention to help them reduce their use and sort of feel more normal in between. So how do we define success in a substance use disorder trial? You'll notice that not a single one of those trials that we just looked at in that other table had any of the DSM symptom criteria as part of their outcome. All of them defined success as negative UDSs. They were very, very stringent. And so does a negative UDS actually tell us if the therapy is working? It absolutely does not. What the clinical impressions are, those 4 categories, those are what tell us if the therapy is working, if people are able to work again, or if they're able to maintain social relationships, if they're able to control or eliminate their substance use for periods of time even, things like that. So that is a big problem that we have with substance use research. The other thing is it's important to counsel a patient what benefit they might see. I tell every patient that I'm giving mirtazapine to, or bupropion, there is no miracle pill. If we had a miracle pill, we'd be giving it to everyone. But what these things can do is that they can help you with your goals, if that is your goal. But a medication cannot invent a goal. So what I would also say for us clinical prescribers is that if someone is coming to you, they're using meth in a chemsex context, but they're pre-contemplated, they're not really ready to change their use, throwing some bupropion or mirtazapine at them, it's not going to make a huge difference, because this is about assisting people with their goals. And if they don't have that motivation, this might help with a little bit with some harm reduction. But I would not say that like a medication by itself, again, is not that social service spectrum. So being realistic about what the effect of a medication might actually be able to do, it might not be able to wipe away all of their use, which is oftentimes what we set our goal as. And then it's oftentimes also difficult with these studies specifically to think about some of those confounders. So rather than go through these bullet points, I'll bring you back to the chart. You can see that Choctaw included contingency management. In both arms, the placebo and the treatment arm. Contingency management, we know, is actually an efficacious treatment for stimulant use disorders. And if you don't know, contingency management is providing prizes to people for not using. It's actually based off of really great research by Dr. Carl Hart. I would encourage you to look at, talking about how people will stop using substances if they have an attractive alternative. And that's why that social service is important. So could that contingency management completely have negated that study, because that is an efficacious treatment, so it can mask the effect of the bupropion. And then again, all these included therapy. So it's hard to say in both arms, but still, it's hard to say what would the drug do if there wasn't also therapy. How would it work in a harm reduction method, like I was just saying, by itself? Again, I don't encourage its use like that, but we actually don't know how it would work. So moving forward again to my favorite study talking about bupropion, it's this one, which was a combination of bupropion XL and naltrexone extended release. This was another double-blind, multi-site randomized placebo-controlled trial here in the US. It was adults, no SOGI data, again, unfortunately collected. So again, not the population we're necessarily talking about, but it was adults with methamphetamine use disorder seeking treatment, and that's a key point. And you can see that they used a much higher dose of bupropion. They actually elevated people to 450 milligrams over 3 days, which is quite fast. And what they looked at is, again, unfortunately, a stringent negative UDS outcome, and they did have some secondary goals. And what they found is there was a small but statistically significant response. So it was effective even with people for moderate to severe use. Remember that those other trials found that it was only effective for people with minor use. Now, they actually did see improvements across the score or across the board on their secondary outcomes like craving scores, depression symptoms, treatment efficacy, and response assessments. However, again, bringing back to why I want to encourage you to start research, to think about this research critically, is they actually were not powered to determine if any of those effects were statistically significant. And if you ask me, those are the effects I want to know about, because that is going to tell me what the actual treatment response is. Because I don't care if in a 12-week period, they reach 3 negative urine drug screens. That tells me nothing about how this person is going to be able to better walk about the world and live the life that they want to live. So those quality of life and those treatment response scores are way more important. And unfortunately, they're all too often missing. So in summary with Bupropion, I think it's an efficacious medicine, probably better for people with lower to moderate use. And again, it's important to counsel people on them. Absolutely, Colleen, once daily use is always going to be easier for people. And the nice thing about Bupropion also can be used during active use. It's pretty safe to do so. And then the other thing about Bupropion that's nice, yeah, you can use safely in active use. That's what I was going to say. Thank you. And then this is just a pull out from that same study. And you can see here the difference between the weighted averages of the urine drug screen show that there was a benefit. Although, again, in this specific trial, we can see that you won't be able to differentiate what's naltrexone and bupropion. And actually, as you can see here, we do know that naltrexone by itself is pretty efficacious. Now, what's interesting to me is why they even use the injectable extended release naltrexone. As you can see in these studies, although foreign studies, the oral is just fine. The reason why we use injectable naltrexone in others is improved adherence, but also specifically in opioid use disorder. It's a lot more efficacious because people don't have to decide to take it every day. But for people using meth, you can use meth on top of naltrexone. It's not going to block anything. And so I find that prescribing this medicine, people don't have an issue taking the oral form. And most people are not in places in their lives where they want to come in every 3 weeks. And I have a lot of patients that I connect with via telehealth for their meth use, which they're very able to do. A lot of them have housing instability, they're couch surfing, but they all have a phone. They all have apps, and they're much more willing to interact that way, and then they can just send them the pills. The other thing I'll say, as you can see in these 2 trials, although foreign, and also unfortunately not in genderqueer people or people who have diverse sexual and gender identities, it was effective. But specifically in the US context, what I like about giving people oral naltrexone is it protects them. Now, contamination of stimulants with fentanyl is rare, obviously, because it is sort of counterintuitive, but it does happen. And I actually have had a patient case within the last year of a patient who was their goal was to reduce their use. I had them on bupropion, mirtazapine, and naltrexone together. They were happy with that combination. And they came to me after one visit and were very excited because they occasionally slammed. And they said recently they had been to a party. All 3 of the people who were engaged in that party slammed at the same time. The other 2 passed out, but that particular patient did not. And he attributed that to taking the naltrexone, of blocking perhaps opioid contaminants in that supply. So that's something I also mentioned to patients because, fentanyl, like for better or for worse, is all across the media, is that this would protect them from opioid contaminants and drugs. And I think that's especially perhaps even relevant, even though naltrexone is not necessarily like a super treatment for G use. For people with concomitant meth and G use, it might also be a great idea because who knows what's in some of the depressants that we're giving people. Although more oftentimes, if we're thinking about G use, it's contaminated with things like Drano, but that's another story. Questions so far? I know this is the meth use one is really, it's the longest haul, but I really want to spend the most time in this because I think this is going to be the most beneficial for people. All right, scanning the chat quickly for questions. All right. So naltrexone is actually, to answer your question, Mary, naltrexone is actually just added to reduce use, and it has been found to be effective that way, but it has the added benefit of that it will prevent people from having any side effects from opioid contaminants. Naltrexone does not reverse whatsoever. It does not affect meth itself. But we know that naltrexone works on the craving center in the brain, which is why it's also effective for alcohol use disorder. And we actually find it's even effective. Oh, sorry, we're into pyramid. This is the wrong one. We'll find it's also effective for binge eating and people who sort of have a use or disordered eating issues where they eat too much because it just works on that center. So looking at topiramate, this is a medication that targets the GABA receptors and glutamate activity. It targets those brain reward centers. We know that it's useful also. It's been studied in a lot of stimulant use disorders, but we know that it's specifically useful for alcohol use. What patients like about this one and what they like about bupropion is it actually causes weight loss. So again, if you're combining these things with mirtazapine, it makes people more willing to take it if they know they're also taking something with a weight loss. But when I'm using this one, I really only use it in people that have done a program or have already achieved abstinence. And my main reason why is because of that renal safety concerns. Giving someone topiramate who doesn't use meth ever, you really have to do close renal monitoring. And then if you add in those using meth, especially injection use of meth, it's just not a great idea. You can end up with someone with AKI really easily. So, and in the research, it's actually even better for people who have achieved abstinence. And actually, to a point earlier, topiramate is a really great thing for people experiencing euphoric recall. Colloquial, that's known what that's what people have known it to be used for in treatment programs across the country. And the reason why, if you're thinking about the pharmacology, is again, it's a mood stabilizer and it reduces excitability. So that euphoric recall is caused by an excitation response. And so topiramate can help with that. And I've given it to a couple of patients, a handful of patients, again, post-rehab most commonly, and they found it very useful. And typically it's something that I only do, in my experience, for 6 to 9 months. It's not something I necessarily want people on for life, also because, again, of those renal side effects, but it can be very efficacious for those people. But people do use it longer term for things like alcohol. Although the other thing I will say is that we're thinking about a combined approach. A lot of the times I have these patients are either also on HIV medication that is TAF-based or also on a PrEP regimen that could be TDF or TAF-based. And so again, thinking critically and really doing close monitor of the kidney function is going to be important for this medication. Although I don't want to say it is efficacious for those seeking abstinence. So in terms of trials, there are 2, one of adults in Iran, one of them of USA adults. Important to note that once again, besides those Mirtazapine studies, no SOGI data was collected. But what you can see is that in the Iranian trial, they actually did see some lower UDS scores, but again, and lower addiction and craving scores. So they actually had some really great outcome measurement. You'll see that rather than just measuring UDS, they measured depressive symptoms. So I think that's great. But in the US study, which I think has a larger sample size, is more robust, I think it's important to note that they didn't see a significant effect for people actively using meth. But again, this is where they said significant abstinence maintenance, that it helped people who were already abstinent stay abstinent. So that's where I really think that topiramate shines. Now we're going to get into long-acting stimulants. We'll probably spend about 10 minutes on that. Any questions? Feel free to add them to the Q&A and I'll get them at the end. So long-acting stimulants, I would say that these are best for people with high levels of use or especially injection or slamming use. Again, thinking about that dopamine pathology, they're going to need something to help them through withdrawals, but also they're going to have like a post-dopamine pathology of it very depleted for long periods of time if there are chronic slam use disorders. Of the options, as we'll see in the research, methylphenidate extended release or lisdexamfetamine are likely the best options. I do not give patients with methamphetamine use disorder either any of the short-acting options, and I do not give them Adderall XR either. For the most part, I don't think it's a good option. In any ways, the mixed amphetamine salt generic is on national back order, but that's a whole nother story. The nice thing too is that there's actually been some studies showing that methylphenidate ER and lisdexamfetamine cannot be used in a way other than intended, either injected or stored. Specifically, the pharmacology of lisdexamfetamine completely renders it useless if injected or stored. And of course, just like any controlled substance, you're going to want to, or like a opioid prescribing, you're going to want to monitor them monthly. But again, treating some of those ADD symptoms, essentially high levels of meth use when you stop using gives you ADD, and treating that dopamine pathology. So these are some miscellaneous studies that I won't belabor too much, using some of the short-acting medicines like dexamphetamine and using modafinil. They did see some improved retention and some general improvements. And yes, these slides will be available after, I think someone said that. But I'm going to breeze past this because for the most part, we didn't see really the outcomes that we saw with some of the other drugs. And specifically, that's related to just sort of the way, the mechanism that these things work. But again, looking at these, they are some USA-based studies, but again, pretty stringent primary outcomes. And except for that last one, Anderson, pretty small sample sizes. These studies, which unfortunately are all foreign-based, but with methylphenidate, I really like these for a couple of reasons. And this is where we get to see that across the board, methylphenidate had a strong, significant response. And that's why I think that it's an efficacious medication. So you'll see that these were people who were in the Nordic area or in Iran. And you'll see that, again, they use the long-acting methylphenidate. And you can see that looking at some of the results, reduced ADHD symptoms, less stimulant use, better retention, and improved depressive scores. So really treating that pathology and getting people and keeping them in care. What I also want to highlight, I'm going to take a breath, is because we didn't fully talk about contraindicated medicines with meth use. And this is where I want to highlight it because this is actually some of the data on that. When we're talking about contraindicated medications, we're going to see the data on why benzos are bad shortly. But if you can see this first trial, the 2007 trial, they actually did a head-to-head with placebo, methylphenidate, extended release, and aripiprazole. And the trial was stopped early because they saw that aripiprazole had a significant increased use of meth effect that was harmful. Antipsychotics for people in active use are harmful. They have been shown to make people use more meth to overcome those effects. Now, we don't know how well antipsychotics might work for someone who is abstinent. And there is, of course, times when someone is actively psychotic from the dopamine pathology and from not sleeping, that, for example, we might have to use an intramuscular antipsychotic, or they might need to be on an antipsychotic for a while, but they should not be treated as treatment for meth use disorder. They are actually counterproductive. And that is a common mistake that I see is people coming out of programs or people in active use who are be giving high doses of olanzapine or Seroquel to sleep. And that could be leading to increased use. So I would not recommend that. Same thing also with some of the more strong mood stabilizers. Again, topiramate has great evidence on it. I would not be using something like lithium, of course, and someone in active use with meth. That's not a great idea. Something I haven't really seen commonly, but I have heard of before. So I'll move right along to lisdexamfetamine. And what I really want to look at is that second trial. The first trial, unfortunately, we're awaiting larger results. The trial has closed, but they have not published yet. But it's an Australian study looking at high doses of lisdexamfetamine for methamphetamine use disorder. This first study at the top was just actually looking at safety and tolerability, and they found that it was safe and tolerable. But again, at that low of a sample size, we can't really conclude that it was effective. But what I really like is this actually second study that was just published, absolutely amazing. It's a very large sample size. It was a prospective cohort, and they looked at exposures to different medicines for people with a diagnosis of methamphetamine use disorder without other mood disorder diagnosis. And their outcomes were hospitalization secondary to substance use, any hospitalization or death, and all-cause mortality. And what they found is that exposure to lisdexamfetamine for people with methamphetamine use disorder significantly reduced the risk of all three of those outcomes. So that when we're talking about the long-acting stimulants, if you're having trouble with these things, getting over that idea in your mind, these things have now been shown to actually do the best thing that we're looking for, which is reduce the all-cause mortality. And what I often think about, especially because I use these most often in people who are slamming, there is not a world in which even high doses of a long-acting prescribed stimulant that is taken orally is not better for a person than injecting street meth into their veins. There just isn't. And so I encourage you to really think critically about that if you have sort of some barriers. I know it can be difficult for some people, but they're efficacious and they're important for people. And it's a form of harm reduction as well. Even if they're taking more than prescribed, which I really don't run into that much, because the nice thing about lisdexamfetamine and Concerta, you can pop a lot of them. It really doesn't get you high. It's just so long acting. It's similar to methadone. It doesn't have that peak that people talk about, especially when it's through the GI things. And the other thing to talk about with this study for lisdexamfetamine is that it was shown that benzo use was actually associated with poorer outcomes. So again, benzos contraindicated. And the other thing I'll add in when we're talking about contraindications is that they have looked at every medicine under the sun for meth use. They've looked at gabapentin, they've looked at amlodipine, they've looked at all things. Another medication that's contraindicated, especially with chemsex use, SSRIs. There has been a study that showed that SSRIs statistically significantly decreased retention. And that is because they have, in their colloquial terms, they make people fat and flat. They reduce sexual drive, they reduce energy. And for people coming off of meth, that's not how they want to feel. They want to feel like they're on meth again. Not necessarily high, but we want to make them feel like energetic, give them back that sexual function. And so an SSRI, even though they might be concerned about anxiety, is not the way to go. It's likely to decrease their intention, and also they're not likely to be adherent with it, as we've seen in the data. Something like mirtazapine as an anxiolytic is far better. So applying this to this case, what medications, what treatment plan would you build? I'd love to see a treatment plan. Yes, to Colleen Hicks' point, some of the studies, specifically if we go back, again, apologize if anyone gets motion sickness, you'll see that in the methylphenidate studies, they looked at ADHD symptoms. And actually what's interesting about that Swedish study in the middle there is they actually looked at prisoners with a combination of ADHD and meth use disorder. So a lot of times, actually, if we're thinking about the European context, some of these European studies, what's actually interesting is that these, again, are heterosexual people. And a lot of the ways that these people got into having an amphetamine use disorder is they started with use other than prescribed stimulants for ADHD. And so by switching these people onto a higher dose of a long-acting stimulant, they found that they were their ADHD symptoms were treated, but they also were not using street meth and they had better retention and care. So absolutely. And I think several of the studies do measure those symptoms because again, people have attention issues after they use meth. They really do. It causes that pathology. To Christina's point, I do have a lot of patients who say that they are going to remain abstinent as a way to treat it because they feel they cannot do it. But in my experience, and again, this is experience-based, it is not sustainable for most of these people to be abstinent for the rest of their life. Maybe some people I found actually have been helpful. They take a year washout period and maybe they'll find their way back to sex. But for people specifically who use in the chemsex context, making a sex life sans substances is important. And so helping them find a way through medications and through counseling back that way is going to be really important to their long-term recovery. And so again, if they're experiencing euphoric recall and they've been abstinent from meth and they are been abstinent from sex, something like some topiramate plus maybe some bupropion and some topiramate plus sildenafil or tadalafil might be a really great option for them. As well as also realizing that they need to lead back in. And this isn't for everyone, but I counsel patients on what apps. A lot of people there are a lot of the apps have different characters in queer communities. If you're using something like Grindr, Scruff, or some of the online ones like BBRT, etc., those are much likelier to lead to a return to use. But something like Hinge, which for queer people tends to be more like the settled downy one, can be a nice lead-in. That's just a colloquialism. I understand that for most of you, that's probably not something you're going to be counseling on, but to that specific question, it's something that I have found helpful. So going back to the case, what medical options might you prescribe in your care plan? I'd love to see a medication care plan. We talked about the social side. Any ideas for this specific patient? Yep, there's dexamphetamine, and a long-acting stimulant. They're slamming quite often. They're going to need something more than bupropion. And that's how I sort of decide between starting a long-acting stimulant and bupropion. I don't start those together because that's too much. Is that if they're slamming a ton, they're going to need something stronger like a long-acting stimulant. But again, if they're in that area where they're only smoking or only eating it and they're not using every day, then maybe we start with the bupropion. And if that's not enough, it's not working for them, then we add, or they're experiencing ADHD symptoms even on top of that, then we add on the long-acting stimulant. And bupropion is an off-label treatment for ADD, so it also is treating those attention symptoms. What other things? So they're concerned for depression, anxiety, and insomnia. We're putting on a long-acting stimulant, but what else might help with those things? Mirtazapine, certainly, for the depression and insomnia. What if they're concerned for euphoric recall? What if they actually decide that they are going to be fully abstinent and they reach a point where they've been abstinent for 2 weeks? What might be helpful for them as well? It's the translation period. We're going to translate this into therapeutic prescribing practices. To pyramate for recall, absolutely. So now we're going to talk more. This case is just for practice. And I also want to use this to talk about how things are different between people assigned between like a cis gay men and the transgender experience of chemsex, especially the trans feminine experience. There is a difference. So in the trans feminine experience, chemsex tends to be much further linked with survival sex work, and the substances are slightly different. Certainly meth use, but also crack cocaine, which is not as common in the cis gay men, is part of this community. And so it's very much tied to sex work, and it's a way that people, especially specifically trans feminine people, can make the underground economies that they're participating in more tolerable for themselves, and a way that they also sort of treat the various forms of oppression that they fall into. Because, you know, our trans feminine people are often, they have very intersectional identities, and they often can be at different stages of experiencing racial oppression, experiencing gender oppression, experiencing transgender oppression all at once, which makes it difficult. So in this case, we have Cherry, who's a 44-year-old female who's assigned male at birth, uses she, her pronouns, with a history of hepatitis C, status post 8 weeks of Gleeplib with sustained viral release, so her hep C was treated. She formerly participated in survival sex work and often partied with meth and crack cocaine with clients. Her goals and circumstances changed, and she's elected to participate in a residential treatment program. She's now completed the program, has not used either substance in 4 weeks, and has translational housing. Really key, if you like the treatment program to housing is important and essential. And she's concerned, however, for insomnia, anxiety, cravings, and euphoric recall. She's excited about her progress, but concerned her symptoms may return to use. What's going to be useful for her? Any ideas in the chat? What medications might you prescribe for this person? To pyramate mirtazapine again, absolutely. Especially for that euphoric recall. And, you know, let's say this was a patient who also had an opioid use disorder. You can use long-acting stimulants, some of these other medicines, as well as something like buprenorphine sublingual or buprenorphine extended release, the injections. Either those, they're safe to take together, and combining those therapies is potentially very key. I recently spoke with a wonderful harm reduction advocate up in New York City, amazing trans feminine person, part of a really great political action committee, who talked about the importance of combining those things and how they were actually hoping that opioid treatment centers in New York City and in New York would start offering treatments for methamphetamine use as well. All right, so we're getting towards the end of time, so we'll end with these last little brief case, which is a great way to take us out, just to talk a little bit about one more substance we've touched on. Andreas is a 39-year-old male who identifies as gay. He uses he, him pronouns. He enjoys sex parties and frequently uses G. He's been living with a friend who deals drugs and has moved from using G 1 to 2 times per week to daily use. He reports he can no longer sleep without G and gets shakes if he goes without too long. So what is some general harm reduction counseling? Absolute number one thing, recovery position. Just the same as alcohol, the way people die is asphyxiating in their own vomit. And this happens, it happens not infrequently. I always use the case of also a bad drug policy of the Atlantis cruise, where the storm chaser person who is gay actually died in that cruise exactly like this, asphyxiating on their own vomit because their friends left them on their back when they passed out from G. There's a risk for overdose. Again, you can pass out, and also to a physical dependence similar to alcohol, where if you don't use the product anymore, that you will develop like DTs, you'll develop tremors and psychosis, etc. Things that can be helpful are those ideas I talked about earlier: accountability, having a friend help you with dosing and time logs and the exact measurements, thinking about drug holidays, taking periods of time with no use to test or control. Of course, since it similarly works kind of similar to alcohol, you want to avoid alcohol, absolutely, and also avoid other things like benzos, opioids, and histamines, unless, of course, you're using the benzo as a treatment for the withdrawals. And then, of course, buddy system and G-sleep supervision. Vulnerable to sexual abuse when you're passed out at a sex party, of course, and so it's important to go with a buddy. And then finally, so this program ends at 1:30. I think there's a question about that. In terms of the medications for this, what I want to drive home today is that the standard of care for someone who needs to detox from G is not just benzodiazepines, but also baclofen. So G works on those GABA B receptors, and so does baclofen. And so it's important to not just use benzos, but baclofen as well. And you'll see in there, both in up to date, as well as a nice published book actually out of the UK, there's a protocol that they've developed as an accepted standard of care for detoxing people from G with these two substances. There's actually also a Dutch open label trial, of course, quality a little bit lower because it's open labeled and non-randomized, but they actually saw that versus treatment as usual, adding baclofen after detox may have helped people prevent return to use and have some more retention. So I'll finish there. I'll skip the bonus case because we have about 5 minutes left. And what I would like to do is just do question and answer. So I believe there were some questions in the Q&A. I'm reading the first one.
Okay.
Actually, Daria, do you want to read it aloud for everyone? That's probably better so that way everyone can see it.
Sure. Oscar is asking when appropriate, he'd like to hear more about the diversity of the Chemsex related clients that you're seeing at Whitman Walker. And he talks a little bit about his experiences on the Texas-Mexico border and some of the innovative approaches they're using there. And then we also have another question about insurance paying for IM naltrexone.
Yep. So I see some great things in there, Oscar, about really working on the shame. I think using non-stigmatizing language is essential, removing abuse from the vocabulary. Really also, when we're talking about counseling, not just motivational interviewing, but strength-based counseling, like focusing on what people are doing right, I think is great along those lines. In terms of the diversity of clients, certainly I have seen clients from all walks of life. Meth use is not only in cis white gay people. I see a lot of patients of color. If we're thinking about the HIV epidemic among sexual and gender minorities in the South, specifically around Atlanta, we see a lot of meth combined with communities of color, and there's a lot of harm reduction, a lot of shame work to be done there. Absolutely, because in that particular area of the country, the substance use disorder services are really not made to meet that intersection of identity between someone who's a queer or gay and someone who is Black. So absolutely, that's absolutely important. And we see a lot of that in DC. I have many patients of color. And I've also worked with patients who are trans feminine immigrants seeking asylum who use meth, especially who used actually stimulants back in their home countries tied to sex work. So it really crosses the gamut. And again, I think that there is that sort of distinction between trans feminine experience and cis experience between more ties to sex work, where I feel like most of the way that people get into party culture for cis gay people tends to be that they start more with the party and then they eventually might, depending as their circumstances change, might get more into sex work, but not necessarily. There are people who start off escorting as well. But there is a difference there. I think it's always important to approach these cases with cultural humility, to think critically about cultural components, et cetera. But I think especially as we think about other cultures, but across the board, thinking about how shame operates in that community and how we can provide them affirming resources for them and trying to find, again, affirming, not stigmatizing resources. And for to the question about the insurance paying for IM naltrexone, I code it as substance use disorder. I don't like the ICD-10s for meth because at least in REMR, they always say dependence after them. And I never write any diagnosis code with abuse in it. And in fact, I take any code of abuse out of the problem list. I think that is essential for people. And so if you just code it as a substance use disorder, you'll see that people, that you will get coverage. Again, I tend to use the oral formulation rather than the injectable because most of my patients prefer that and don't want to come in every 3 weeks. And I've never seen that denied. But with the injectable, again, if you're coding it as a substance use disorder, there should be no issue with coverage. It's an old generic. We have 2 minutes left, perhaps time for one last question. Is there anyone with a last question?
Yona, in the chat, there are 2 questions. So from Jonathan, would you be able to point towards anything on the purity of the meth supply? We operate under the assumption that much of our supply has opioid contaminants.
Yeah, so this certainly is an area where I actually know, at least in the DC area, we're trying to actively, I know some of the agencies here at Forensic Science are working to collect meth syringes. So that way they can analyze that. That's, again, great work that HIPS here in DC is spearheading. What we likely know, I think, again, there's a lot of sensationalism of fentanyl over in the media. And generally speaking, you should not expect that a lot of stimulants contain fentanyl, especially if we're talking about meth. Just specifically meth. If we're talking about crack cocaine, you're likely to see like more contaminants and that. But I would say that across the board, I think that it is not a bad idea to tell people to test all of their drugs. There are also really great kits from dancesafe.com where you can actually, they're drug testing kits that will tell you if the substance you have is ketamine, is meth, etc. And then that combined with a fentanyl test strip, then you can really be safe. So yes, I do recommend those counseling interventions. What I recommend against is using scare-based tactics, saying your drug supply, your meth could have fentanyl in it, and trying to scare them out of using. That is not effective, and I think that that kind of sensationalism is not helpful, but absolutely I counsel them on the risks, and I give basically everyone Narcan. And you know, the reason why I do that is I'm not necessarily just saying it because you might need Narcan because you're gonna experience some sort of like opioid in your supply. You might need Narcan because you're walking down the street and you see someone overdosed, or you're on the subway. Here in DC, we see a lot of people passed out on subways, on streets. We have a large housing crisis here. And so I think everyone should be carrying Narcan.
Well, thank you very much for a fabulous talk, entertaining, informative, and engaging. And thank you to the attendees for your engagement as well. In the chat, you'll also see a link for the evaluation. So please complete that. And then after you complete that, you'll all get your certificate attendance or your continuing education credits if you so desire. There's also a link to our website that will list the future webinars in this series, and we look forward for you joining us for those as well. Again, much appreciation to our speaker. Thank you very much, and have a great weekend, everyone.